Good morning, everyone, and belated Happy New Year. I think this is the first of our meetings into the new year. And welcome to Safeguarding Education Overview and Scrutiny Committee. I know that we are joined this morning by Adrian Green, who I understand is replacing Mr. Wood as the chair. And also, correct me, is it Stephanie Kincaid-Banks, who's the business manager? It may be useful just before we start the agenda if we go round just for Adrian and Stephanie to perhaps understand who everyone else is here. I'm Bob Spencer, I chair this group, and I'm an elected member for Codsall and Bilbrook in Staffordshire.
I'm Conor Wileman, and I'm the elected member for Burton Tower Division.
I'm Gillian Pardesi, elected member for Stafford Central.
Good morning, I'm Steve Bell. I'm a co-opted member and I'm the Director of Education for the Catholic Archdiocese of Birmingham.
Good morning both. I'm Paul Snape. I am the Vice Chair of this committee and I'm the elected member for Cannock Town Centre.
I'm Johnny McMahon. I'm the councillor for Hensford and Rawnsley and Cannock area.
Hello, I think you both know me, but I'm Ruth Martin, Principal Social Worker and Safeguarding Lead for Staffordshire County Council.
Good morning, I think you both know me as well. I'm the Cabinet Support Member here at the County Council with responsibility for safeguarding in my portfolio. Thank you.
The Reverend Michael Metcalfe, representing the Church of England as a co-opted member.
And Helen Phillips, and I am the support officer for this scrutiny committee.
Thank you all for that. We'll go on to the agenda then, and item 1, apologies.
So we have a number of apologies this morning, Chair. We have apologies from Mrs. Burnett Faulkner, from Mrs. Edula, from Mrs. Jessel, Mrs. Perry and Mrs. Eagland. Thank you. Item 2, any declarations of interest? If I could make one myself for item 4, well, I say it's the only substantive item. I have a close relative who is a member of the joint team, only just started. Moving on then to item 4. Which is the substantive item, Stafford Stoke-on-Trent Adult Safeguarding Partnership Board annual report. Adrian, did you want to say anything to open the debate, or shall we move on to, is it, Ruth, are you going to run us through the report?
I'll unless Ruth really wants to, I'm quite happy to run you through the report as it stands, and then take any questions thereafter, if that's how you would wish to do it.
I'm more than happy for that, Adrian.
Thought you would with your cold.
Thank you.
Croaky voice. Well, good morning, everybody, and thank you for hosting myself. This is the annual report for the Joint Safeguarding Adults Board for Stoke and Staffordshire for the period 23-24, and that came under the chair of John Wood, who wrote this report. Just to remind you that the vision of the board is to look after adults with care and support needs, to make sure that they're supported to make choices to live in a place they feel safe and secure, free from neglect and abuse, and that includes exploitation. And just to make sure everybody appreciates that, it is the people with care and support needs that is within our remit, and that is different to children's, which covers all children irrespective of their circumstances. And we are a statutory board supported by an exec group and a number of subgroups, which I will go on to through this process. Our overarching outcome is to ensure that there are safe and appropriate partnership safeguarding arrangements across the area. And to do that, we've have to deliver a 3-year strategic plan. We have to report on that annually, which we're doing today. And we have to ensure that where there are incidents that leads to death or serious injury, we consider whether a safeguarding adults review is required to understand what learning opportunities may exist to prevent reoccurrence. And to help us do that, we seek assurance, and you will have seen within the document, John has laid out a significant amount of assurance that the board has received within the reporting period. But I think the standouts, in summary, were from the police. We had assurance around this restructure of the public protection unit, their pilot for pit stop, which is still in pilot at the moment, and the introduction, which has now commenced in February of this year, of the right care, right person process, whereby police are withdrawing from attending certain incidents regarding mental health, etc., and ensuring that our partners who are properly trained and equipped with the right skills actually are the people who attend and deal with those incidents. We've had presentations from Safer Custody, because although we're not responsible for prisons and refugee asylum, we are obliged to seek assurance that the Care Act principles are being followed within those establishments. We've had assurance around out-of-area placements and also around dolls, which we'll talk around when we get to the data section at the end. In terms of audit, we've completed the Tier 1 self-assessments from the different partners. We've completed a Tier 3 audit involving 30 dip samples of safeguarding concerns involving, in that process, 50 GPs. And we've added mandated question sets to the future Tier 3 audits regarding mental capacity assessments, lead professional allocation and escalation. But if I were to summarise what the key issues from the audit team have found, identification of a lead professional, hence the reason we've mandated that within the question set, a lack of follow-up after referral, single agencies retaining risk. And in summary, that would be around referral being as an outcome. What I mean by that is where somebody receives a referral, they forward it to another agency who's probably better placed. They close it down, often because nobody's answered the phone or responded to letters, and the originating agency still thinks that they're being looked after by that other one. And the other one is line of sight. Often we get GPs in particular who are asked to pick up the observations of that individual, and they'll do that by telephone, and we don't have a line of sight on the individual, and that's very prevalent within self-neglect. We've got inconsistencies within multidisciplinary teams. There's a lack of understanding regarding self-neglect, in particular the protocol, the decision matrix and the guidance. There's issues of engagement, consent and advocacy, lack of detail in records, and issue with disparate IT systems across the partnerships. And the self-neglect pathways have already been reviewed, but we have now brought this in as a single priority item for the period 25-26. In terms of SARS, we've had 7 referrals, 6 of which didn't meet the criteria. 1 did, and a formal independent author has been commissioned to undertake that. 3 of the 6 that didn't meet the criteria, it was felt that there was learning, and so single agency reports have been commissioned, and we will use the SARS subgroup to deliver that learning in any event. In terms of the SARS that we've had published this year, we've had SAR Gillian. SAR Gillian is a tragic case which identified issues of self-neglect, bereavement, professional curiosity, and the effectiveness of multidisciplinary team. We also had Frank and Elsie, which is an interesting case demonstrating emerging issues with regards to sexual activity and relationships within elderly people in care homes. and in addition to sexual assault and unwarranted sexual advances by residents to staff, and how they deal with that, how they do appropriate placements, how they understand and do effective risk assessment. And that is the SAR, Frankie and Elsie. And a lot of work has been done around trying to inform staff. There's been a Mental Capacity Act and Sexual Safety Consent workshop. 104 people attended that. There's been work on trying to promote proper use of language so that it's shared across partners, and also gives staff the comfort of discussing very sensitive issues with residents around their sexuality and sexual behaviour and true consent, and at the same time trying to respect privacy. The Treacy SAR is one that covered a period of 1991 to 2023. Many of the things had already been put in place through changes in legislation, technology and practice, but there were 3 items that were escalated to government, and that's been done through the National Sub-Chairs group. Looking at the subgroups in terms of engagement, that subgroup meets every 2 months, and it looks at engagement and prevention. And there's been a lot of work done by that group to raise awareness, constantly trying to raise awareness of what neglect and abuse is, how you identify it, how you can report it, and what you would expect having reported it, so that people are informed. And in addition to that, there's been online learning events. We've had 727 people attend those. We did an event on self-neglect and mental capacity, and 191 people attended that. I've already mentioned the 104 people who attended the mental capacity and sexual safety input. And we've also had input on managing allegations against staff, and also one on domestic abuse relating to older people, which is obviously an emerging issue with particularly financial control and coercive control, and 156 people attended that. So in total, 1,300 people have attended inputs on things that the board have felt were specifically relevant. In terms of our strategic priorities, making safeguarding personal, that's a golden thread along with legal literacy. And we have continued to offer support, embed training in practice, and it features within our KPIs and involves the issues of advocacy and involving family members and wider kinship networks in our interaction with people with care and support needs. We've also done a quarterly audit across the safeguarding pathways, and we've done decision making on Section 42 thresholds. Section 42 is where we've had a concern and it has warranted further investigation and inquiries. Those audits identified that 3/4 of the people were offered the right support. Almost all of them who could be were enabled. Almost all involved the appropriate agencies within the work that was undertaken. 87% were felt to be proportionate responses, and there was evidence of effective end signposting. So at the end of the investigation and the services that were provided, people were offered further support and information. And almost 100% achieved full or partial completion of the desired outcomes. And I'll go on to that further when we talk about data. In terms of DOLs, there is a backlog with DOLs. There's a lot of work that's been undertaken upon them. The government's proposed replacement for DOLs has not happened. There is no indication currently that it will, but I have been informed that this new government might be re-energising their views on it. And so we're stuck with the old system, which government have already accepted isn't working effectively. Staffordshire have improved performance on this. The training that has been undertaken for people has increased so that we can increase capacity. And of the 144 DIP samples, 75% of people very satisfied. 94% felt that the process was respectful, 90% felt that they were listened to and given the time, 91% felt they'd been appropriately informed, and 87% felt that the process was proportionate and meaningful, and 80% thought appropriate. We've endeavoured to improve self-neglect, and I think it's fair to say that we have improved the ability of practitioners to identify self-neglect. And I think as we've delved into that, it's identified other issues, particularly around multidisciplinary team, about practitioner activities, and particularly about the conflict between people who want to not consent to issues of service support and how practitioners deal with those. And Sir Gillian is a very good, strong informer from a fatality that has led us to understand that better. And now we've just had 2 more SARs where we've commissioned an independent author to delve deeper into that learning and help our staff and partners effectively deal with self-neglect better. Linked to that is a trauma-informed learning approach, and we've had, as I said, 125 people attend support and courses on that. In terms of appreciation of risks, there is an increase in out-of-area placements and issues around discharge, and there are issues around transition, both for young people in their journey into adulthood, and that is a new individual priority for 25 onwards, going to board at the end of this month for ratification. In terms of hidden harms and the gaps, featuring particularly for drug and alcohol and elderly people at home, Staffordshire's data quality has improved, and they are part of the dynamic support register that looks at complex and co-occurring issues, and we have done and reviewed the people in positions of trust policy and procedures. So looking at data, you will see from the report that Staffordshire have had 15,810 concerns. That's high when you look nationally. The repeats within that group are 17%. And when you look at the conversion of those concerns to Section 42s, it's around 19%, and the national average is 29%. There is a belief that that 15,000 contains a lot of concerns that perhaps shouldn't be there. We know that we get concerns from police that we wouldn't describe as referral, and we also get ambulance as well. But we are content that the range of concerns include requests for support. They range from the trivial to the very serious, and that means that 15,810 probably dilutes the Section 42 number, hence the reason that it's low. We've done audits on this, and we're happy around the risk, and I'm sure Ruth will talk about this later. So whilst it's high, I think the real concern with that is the amount of capacity that it might take from safeguarding assets within Staffordshire Council. 56% of those concerns relate to the over 75s. That isn't surprising, and that's obviously kind of within the last 5 years for a male and 8 years for a female. The top 4 are neglect and omissions, financial, psychological and physical. When you look at the support for individuals, then it's around physical, and that's the mobility. It's about mental health. It's about learning disabilities and mental and cognitive issues such as Alzheimer and dementia. In terms of where they come from, 67% are in their own home, 13% within a residential establishment, 11% within a nursing establishment, and 2% within acute hospital, which is half of what Stokes is. So if you look at within a kind of residential setting, whether that be home or otherwise, it features around 91%. when you look at the group of Section 42 people, those that were asked what they wanted from the intervention of services, 63% responded. And of that 63%, 91% felt at the end of the interaction with services that their desires had been fully or partially met. That was down from 97%, but I can reassure you that it's currently back up to around 96%. And I do think that Staffordshire, I know Ruth and I have had this comment before, I do think Staffordshire beats itself up a little bit around what it's actually trying to achieve. And so what I mean by that is that it's including things that aren't safeguarding and cannot be delivered within its partially met statistics. So I think they're performing higher than that in reality. When we look at dolls, there is a backlog with dolls. There was 8,766 received. That's up 16%. That features nationally. Dolls are going up. I think we can take some comfort in the fact that 4,000 of those weren't authorised because of the change in location. In terms of the best interest assessors, that's been increased capacity within Staffordshire. But there is a backlog, and I know that there is a concern around that, and I know there are plans in place to actually increase capacity and address that, and I'm reassured that that's the case. In terms of financial assessments, these are a target of 45 days, achieving that 36%, which is disappointing. The backlog is small. So they had 8,203 completed, of which 5,810 were new. The reason why I focus on that is because it causes stress within people with care and support needs. And so I think it is quite an important feature. So that's a whistle-stop tour of quite a lengthy report for this period. Happy to answer any questions, and obviously Ruth will join in if there's any that's more relevant to Staffordshire and herself.
No, thank you for that. Thank you for detailed explanation of the report. Are there any questions? Perhaps I could start then in that case. Just as a general issue, we do seem to have, I suppose if I refer to page 56, about the total number that we have, and I think you yourself described the figures as high. We also have, I don't know whether the repeats are high, but roughly 1 in 5. Yet the section, is it section 42?
Yeah,
42,
the 42.
Referrals seems to remain relatively constant at around 20%. If we think that the other 80% of people who have thought that there is something wrong and asked for help, can we be reassured that there is some help and assistance for those individuals, even if they don't meet that particular threshold?
Yes, absolutely.
And secondly, I know that we concentrate here on the impact here in Staffordshire, but it is interesting, isn't it, to have a comparison to another local authority, in particular Stoke. And is there a concern here about the sheer number, again, that you describe as high, could be, and I think you also described it as diluting sometimes, some of that information. Are we happy that we are not overwhelmed by this high number and therefore are missing potentially serious issues? And I then just look over to Stoke-on-Trent's figures, and since I think it's October 23, they seem to have made a significant reduction in the overall number of referrals that are made. Interestingly, it doesn't seem to impact at all on the number of Section 42 inquiries, which I think is interesting in itself. Are we here in Staffordshire missing a trick about trying to reduce this down, so we therefore reduce the likelihood of missing something serious?
Okay. So the national average for Section 42 conversion rate is 29%. It's a figure that the government say we don't need to really report on, but everybody does because it's a good litmus test. But if I were to tell you that in another area that I chair of 4 local authorities, those 4 local authorities range from 18% to 68% conversion rate, you'll realise that the figure is nuanced to the practices and processes within that local authority. And that's the difference between Stoke's reporting and Staffordshire's. So I'll deal with that first. The process is exactly the same, but the recording point and threshold is different. So we can be very confident that what Staffordshire does and what Stoke does are the same processes. In terms of the number that's coming in, I think the fact that you've got such a high number demonstrates the fact that things aren't being missed. So it's actually the opposite is true. And all of those are triaged. So every one is looked at, and where appropriate, they are re-signposted. They receive services from a different source, and only those that require investigation are followed through as a Section 42 inquiry. So all of those will have received inspection and action. Some of them are requests for assessment, some of them are regarding quality of service issues. These shouldn't really have come in through the concern referral route that they did. The police are under pressure from HMIC, their own inspectorate, to share everything. The police view them as intelligence, not referrals, so they will share. Ambulance seem to have a very low level before they will refer. So we scoop them all up. So I think you can be very confident that nothing is being missed. I think there is an issue, and we were talking about this at the scrutiny meeting on Monday, is does this impact on the capacity of the resources available for safeguarding within Staffordshire, in that you've got to churn that number? And are there some efficiencies that actually other areas of the business could actually take them at source? So that's being explored. But in terms of assurance, I think you absolutely can be assured. I also think Staffordshire take issues on the chin, and we talked about this on Monday as well. They scoop things up and they don't close things down quickly, so that they remain in the system so that they can have their review and audit oversight. And that's quite commendable, but it impacts on the appearance of their data.
No, thank you for that. And that is very reassuring when we look at the facts and figures. Also, in these sorts of circumstances, there is very often that statistical sort of Pareto type business, isn't there? Of you know, I think I don't know if we're losing you. Oh, there you go. That, no. Yeah, 80% of the resource going to 20% of the people, and a lot of times the way to tackle some of these issues actually is to tackle the repeats, isn't it? Because those are probably those people that form that 20%. I note that ours is very roughly 1 in 5. Yeah. How does that compare with other local authorities? And do we recognise the need to perhaps reduce the number of repeats, as that might be the most economic and effective way of reducing abuse in this particular cohort?
It's not repeats in terms of failure demand. It's repeats in that they will have had referrals from multiple services. So you might have had a referral from a district nurse, and at the same time, because of incident, a similar referral comes in from ambulance. So what that figure is trying to say is, out of the 15,800 that you've got about 17% that relate to the same incident or the same set of circumstances within a very short period of time. That's what it's referring to.
In that case, then I suppose it begs the question, do we measure repeats of people who reappear in the system on a regular basis? Ruth?
I'll answer that one. We absolutely do monitor repeat concerns, and where there has been, say, a closure of an inquiry and then a further incident since that actually will then alter the level of response and the level of risk rating that we give it. So the way our risk rating works is that if there has been a previous incident, and there are some circumstances where unfortunately people will be at continued risk, our expectation then would be for those to all have a safeguarding plan in place. So although it's a repeat concern, it's not a new inquiry and will be considered under the safeguarding plan. And you can think about situations, say, for example, of domestic abuse, where there might be a likelihood of a recurrence of those incidents. And that's not to say that we're not doing what we can to minimise those risks, but those repeat concerns will be will heighten the level of risk that we have, and it's an indicator of an increasing level of risk.
Thank you for that. I think that, again, is very reassuring. I think we've had this report, well, I've seen these reports for several years now. One of the concerns I think I expressed right at the very beginning is around some of the criteria, that being that there is a need for care and support, the individual needs it. And this, to me, is this somewhat worrying third limb that they're unable to protect themselves. And it's interesting when you talk about domestic violence, because I know I've raised this before, that does that create a set of circumstances then where we accept levels of domestic violence if we think that the individual is capable of protecting themselves? And therefore, how do we monitor that longitudinally to make sure that that self-protection continues?
I think this is a really complex area of practice, and I know I've said this before. The ability to protect somebody or inability, the Care Act makes it really clear, and this is, as I've said to you before, has been defined by the Care Act. This isn't something locally that we have, that we work to. This is Care Act definition, and their ability to protect themselves has to be directly linked to their care and support needs. So circumstances on their own don't necessarily lead to somebody being unable to protect themselves. However, what we will always look at is balancing the risks somebody faces with their care and support needs and their ability to protect themselves. So where risk is high, I hope I'm going to explain this while my brain's a bit fuddled. Where risks are higher, our tolerance levels, as it were, to somebody's ability to protect themselves may be seen as slightly lower, if you know what I mean. So we're more likely to intervene where risk is high. Because what we've got to do as well in adult social care is balance our duty to protect people, but also people's ability to have control over their own lives and also engage with our services when and if they choose to. There are lots of other services as well who are able to support and protect people, particularly in domestic violence. So for police and the domestic violence services. So it isn't just our responsibility in that sense. So it's around looking at who else is available, balancing where those needs are, looking at what our involvement is, and actually if our involvement is going to as well add and support people. So it's that constant balancing, but this is the, as I call it, the grey that's within adult social care and adult safeguarding, as opposed to this just being about adults. It is these parts that make it necessary. And you know, I know we've discussed before about we've all got the right to that sort of private life, and our interference as a state has to be warranted and justified. And that's why we have to consider the person's ability to protect themselves, because that's written within our legal framework. But I am assured through the audits that we do that that's done carefully and with consideration against the risks.
Can I just perhaps add as well that we aren't the lead agency for domestic abuse. And so we put a lot of work in with Police and Crime Commissioner and the community safety partnerships to make sure those individuals who are subject to domestic abuse with care and support needs are flagged up appropriately. And my view is that we should reassure them that the care and support needs are being effectively dealt with and given, so that they can use their skills, their capacity to deal with the domestic abuse issues. So that's my stand on it. That I want to make sure that that isn't a feature which makes that individual more vulnerable, notwithstanding the consent issues. And one of the growth areas in this is around our elderly community, where changes in recent legislation with regards to financial control and coercive controlling behaviour, they weren't unlawful before. And so you will have many people who perhaps aren't aware that actually the abuse that they're suffering from now is unlawful. But you also get changes in behaviour where domestic abuse grows in an older person's relationship, and I want to make sure that people understand that they don't need to suffer in silence, and that there is support and care for them from the domestic abuse side, and if there are linked things with care and support needs from a safeguarding perspective in terms of social services and health, etc., that we are ready to be able to support them with that.
Can I just a slight other challenge then around that? Because you talk there about sort of vulnerable elderly people, and naturally I think that's where your mind goes to when you think of these particular things. And it was interesting, Ruth, when you talked about people have rights, of course they do, but isn't by definition, as soon as you agree that they have met a threshold for a Section 42, we've already, as an organisation, made up our mind that we intend to breach their Article 4 and 8 rights. And therefore, once we've done that, how do we then, and things like, we say a 90%, 95% satisfaction rate, are we asking people that we have already made a decision that are extremely vulnerable because of the definition? How confident are we that they are in a position to make a judgment about how satisfied they are, or how satisfied we are as a local authority that we are carrying out our duty to protect them from whatever the threat and risk might be?
Well, I think that's the... Oh, go on, Ruth.
No, if you want to go ahead, Adrian, first, that's fine.
Well, I was just, I think that goes back to the heart of the matter in terms of the support, care and support needs. So the Section 42 inquiry looks at the care and support needs. You could have a fit and able person who is subject of a domestic abuse inquiry, particularly from the police, and they literally refuse to separate, they refuse not to cohabit with that individual. There's lots of instances where they go to court with them, etc. And that's where, you could say that there are inquiries that are looking into their privacy, etc. But at the end of the day, they have a right to live their lives as an adult, and unless they consent to the prosecution or they consent to leaving and therefore getting support, they have a right to housing, etc., then they remain with that offender, and there is nothing that we can do about that unless they get incarcerated, certainly on a permanent situation. And so it's about how do you wrap oversight and support in that continuing situation. So it's the same when they've got care and support needs. We want to do a Section 42 inquiry to make sure that we are supporting them appropriately, that they have effective capacity, that they understand what the options are for them, that we might put in visits to the home. We want to make sure that actually the partners who are responsible for delivering the support around the domestic abuse elements and that enforcement and that action is being appropriately undertaken. So that's the distinction between the Care Act elements of it and the criminal elements of it. I don't know whether you want to add anything to that, Ruth.
Yeah, I'd only go on to add that obviously we're guided as well by the principles around safeguarding and how we respond. And one of those is around proportionality, least restrictive. all these things that underpin the way that we work are those things that we'll consider. Where somebody has met the criteria, yes, you're absolutely right. We have a legal basis then for interfering in somebody's life and a right to do that. Our powers beyond our duty to make inquiries and to engage with the person are, quite limited. We have the ability to go to court. We can also then use other pieces of legislation, such as the Mental Capacity Act. So where we've got concerns about somebody's decision-making, we've obviously got the Mental Capacity Act to support us in making decisions in somebody's best interest. Where people have capacity, though, our options are sometimes relatively limited and are around us building relationships and hopefully developing a way of being able to support that person. And where risks are considerably high in life of risk, then we have things such as inherent jurisdiction, requests to the High Court that we can seek to take. But these are things that we've got to, be really clear about why we're sort of doing that. But we have done that in situations, and actually the two situations that really come to mind are those where domestic abuse was a concern for people who had needs for care and support. So we will take those actions where needed. It's where people don't meet the criteria where I say, we then have to think about what information, advice and guidance we can still give to people and how we can signpost them. But we may not have our legal basis then for, taking those actions. But as I say, we risk assess that and look at that and think about that in the widest context. If somebody consents to us, and actually we can, consent to going out there and speaking with people even if they don't meet our criteria, and, that makes it very clear as well that we can. So where people consent, we will often have those conversations, signpost people and support them. Where they don't consent, that's where we have, where we may not be able to provide that information, advice and guidance to them.
No, thank you. I think that lack of consent is clearly an issue, and it must be a very difficult thing, particularly to achieve that proportionate or proportional response. Just a couple of other things within this, and the usefulness of being able to see our performance with a small p, I suppose, compared to another local authority, is that you do see some changes in, for example, when we look at the ethnicity and location of some of the abuse. It's quite concerning that the number of people who we don't know their ethnicity, I think we did around 4%, and it's increased, I think probably doubled that, if I read it correctly. And actually that 4% would make up most of the ethnic minority proportions in the table. So therefore, if that 4% of unknown was the smaller ethnic minority groups, that would make a significant difference to those figures. And when we look at, for example, where most of the abuse takes place, here in Staffordshire, it's in their own home. The proportion is halved in Stoke-on-Trent. Are we satisfied that that is a true reflection of the situation, or are the two local authorities counting or making judgments in different ways? And we talked last year, didn't we, about this hidden abuse that might be out there, and our responsibility to make sure that we do everything we possibly can to find that hidden level of abuses. Would it be more concerning and worrying if those figures tended to indicate that there are issues that we're missing? Again, I think if you look at independent care homes, there's quite a big difference. Is that about recording? Does it reflect the area, or is it more concerning about the fact that we're missing things?
So this is in comparison to as well last year's data. If you remember last year when I came here, I said we weren't recording certainly location correctly necessarily on the system, that wasn't always reflective of whether it was in somebody's own home, and we weren't including supported living as being within somebody's own home, which we now do, which is why actually ours from on this year's gone up. If I'm right, I'm just checking my data now. Make these notes, then I go, am I right? So yes, so that's gone up now, so it's 67% this year, and it was a lot lower last year. I'm more confident in that data this year that this is an accurate recording. One of the things that I realised that we did was around how we will, if we've got some unknowns, we make an assumption over some of our data, or we had been, on location, which this is now being corrected. So I'm quite confident where our data sits, where our location of the abuse is. I think you're absolutely right regarding ethnicity. It's still a concern that we still have 4% where this isn't known. Some of that is related when we've looked into it because the person referring in is referring somebody who hasn't been previously known to us. We then haven't been able to maybe contact that person to establish their ethnicity, and we do it on the person's view of the ethnicity. And we've had conversations now about splitting that and having a person defined and then a referrer defined, so that the referrer can define it for us, as it were, and then we can then clarify that with the person to then ensure that we've got some accurate recording around that. But I completely agree, it does leave us with a bit of an unknown. I would actually be more concerned, if I'm honest, that if that doesn't relate then to the, if those 4% all turned out to, say, be white British, I'd then actually in some ways be more concerned, because it goes to show that actually we're not getting referrals in from all areas of our communities. And what we do know is that there are some accessibility issues, or there certainly has been expressed accessibility issues with regards to some of our services more corporately, as well as not just specifically to Staffordshire, for some of our communities. So I think it's around us continuing with the work we've started to engage with our communities and with the community champions work that's ongoing with our public health colleagues, so that we can start working more effectively, getting safeguarding messages out there to all aspects of our communities, so that actually we start to get those referrals where we need to, and that we're able then to respond in a more effective way. So that's sort of my position, but we have started that work, and hopefully over the next 12 months that work will bear fruits.
No, I think that's good news to see that it is one of those things that we've recognised and we move forward, because when you read the data, I think it's almost futile, isn't it, to record levels of either referrals or populations to minuscule percentages, 0.1 of 1%, if you've got 4% that you don't know, so it does throw some of those into doubt, but it is very encouraging to see that we've recognised that and we're moving on. Could I just also then just move on to the themes, and it's the first time I've seen the themes as we move forward. And please forgive my bluntness on this, but theme 1 about making this personal, isn't that stating the obvious? I thought that when we look at these things, it is very personal, isn't it? The criteria is that a person is facing this, there is a threat and risk, and they, as an individual, can't protect themselves. I just wonder why we include that as one of the themes, when actually surely that is the way that safeguarding should be working in any event. The other point, if I could just make the other two points as well, the slight concern that I have is that if we identify someone, and we've been through and rehearsed those debates, haven't we, about proportionality, and we've already come to a conclusion that these individuals, we are going to breach their rights because they have a vulnerability that we need to protect. And one of the themes is that once they're in the system, when they're transferred, we might lose them, unless I've misinterpreted number 3. So I just wonder if I could have some reassurance and more information about why we have those two things as themes moving forward.
So on the first one, making safeguarding personal is actually a all but mandated model with 6 pillars or areas that practitioners must follow. And it's about accountability, it's about transparency, it's about proportionality, it's about involving them and their wider family in the actual process of designing the services to support and care for them. There's 6 pillars. So when that was brought out nationally, that's when that theme was brought in to deliver that to all of the practitioners and care providers. So it was a piece of work to deliver that model of service provision. Board is taking the next 3-year strategic priorities for ratification at the end of this month. Making safeguarding personal, the bulk of it has been delivered, and so it doesn't feature as a strategic priority going forward. It is a golden thread, like legal literacy, that all practitioners have to demonstrate that they're following those principles. So that's why it was a single piece of work that needed to be delivered, and that's why it was a priority to do that and put in for reporting purposes in the strategic plan. In terms of transitions, you've got 3 areas of transition. You've got youths moving into adulthood, which for health starts at around 14 and for social services closer to 16. You've also got transition of service, and you've got transition of area. And that can, for both of those, include prisoners, etc. It can involve people who are put into a service provider out of area because of their speciality. And that can be sometimes a long way away from where their support network and families are. Or it could indeed, but they're put into an area outside of ours because of family connections. And it's just making sure that we have the oversight continuing. There's a thing called the Host Commissioners Protocol with the NHS, but it's about making sure that we still are satisfied that it's the right placement, that they're getting the care and support needs, they've got that wider support. And there have sadly been SARs, and the Andrew SAR is an example, the Tracy SAR rather is an example of that, where people haven't had the oversight and the continuing protection from the source provider or source local authority that they should have had. And there is a big issue at the minute with people with co-occurring presentations, particularly around disability, learning disability and autism, where they're in the wrong establishment and they are suffering. So you'll be pleased to hear that actually under the new 3-year strategic priorities, transition features as a separate priority around those 3 areas to make sure we're doing as good a job as possible and we retain that oversight, and we only send people out of area either only for good reason, and that could be specialist services and family. There's a very big case of Walton Hall in County Durham, which really demonstrates the risks of out-of-area placements, and we should try and minimise those as much as we can.
Thank you very much for that clarification. 2 final points, you'll be pleased to know. The issue when we raised about dolls, and I understand the backlog and the need to get that done, do we have any risk assessment around the how long we can leave that, what the processes are? This again is about rights and breaching them, of course, isn't it? And we've already had that debate. I just wonder whether we have a risk assessment around the fact that we do have a backlog, just to make sure that that's not going to come back to bite us.
Shall I answer that, Adrian?
Yeah, you can, Ruth,
Yeah.
if you wish.
So absolutely, we follow the ADAS risk guidance around assessing each referral as it comes through. This is also something that's reported corporately, monthly, so it's on the SLT risk register, and the numbers get updated every month. What I would say is this is a continuously, improving picture. So every month we're getting better. The other thing that I would say is that people are waiting comparatively less amount of time. So although we're not still, everybody isn't seen within the 21 days they should be, we're averaging sort of 36 days, I think it is, to the most of being 59 days. But that does fluctuate a little bit. We have put in place new protocols with our hospital partners, and those are working well. And overall, this is something that we feel very confident in. When we compare ourselves nationally to our national comparators from a DOLS perspective, we are second best within our comparator group. So our completion rates, our timeliness rates, and our numbers that are outstanding are very good. It's Bedfordshire who are better than us. Whatever they're doing, I do not know. But Bedfordshire keep beating us to it. But we are in a much better position. And as I say, this remains a priority, and it remains a risk, because we are still aware that whilst we hold a backlog and don't see people within timescales, we are breaching our statutory duties, and we take that very seriously.
Thank you for that.
Can I just add as well from a reassurance point? Ruth's talked about the local performance. The national performance, the average is 165 days. When you look at the 8,000, I think it was 8,000 DOLs submitted, 4,000 of those are cancelled because of a change of location. And that's what the new process sought to address, so that it made it a person-specific restriction rather than a place-specific. So you've got a lot of churn that the council are having to process, which is irrelevant. What I look at is the risk that's involved. And when you look at that, yes, it's a breach of our legal statutory responsibility, but I'm very confident around Staffordshire's triage process and the prioritisation that they put on to the DOLS application with risk. I'm content with the advocacy. Now, Staffordshire's advocacy is lower than where it needs to be, but it's done a massive jump in 12 months. So that's really good. And advocacy is part of the DOLS process. And when you look at the analysis at the end of the process, I'm again reassured that the ones that went through that process, ultimately most of them have died within that waiting period. And so I'm really content that the risk is being managed effectively, albeit we'll maybe get some criticism from CQC inspection around having a backlog. But ultimately, you know, if you were to put increased capacity into doing the DOLs, it would come from somewhere else. And if that came from frontline safeguarding, then I would say that wouldn't be proportionate to the risk within that waiting period, if that makes sense.
That makes absolute sense, and I couldn't agree more. I think that's a fantastic answer. Thank you. The last one from me as well, when we talk about these issues, especially when it is a multi-agency partnership approach, and I think, Andrew, you talked earlier about this business of professional curiosity, that normally means that a lot of those agencies rely on training and inter-agency training with each other to improve their particular expertise. And just when I looked on page 71 and he talked about the budget and the financial report, training resources and catering, so if you take out catering, I don't know how much the sandwiches cost, but about £2,500 from a £140,000 budget. I just wonder, is that indicative of the level of training that we do, or
No.
is that just training resources? Is that books and various other things? What sort of commitment can we be reassured that there is around the partnership and some joint training in what is very difficult and challenging circumstances? Yeah,
okay then. So just to reassure you, certainly in my time, we haven't spent anything on sandwiches as yet. So, you know, it is a tight budget. This board is different to most boards. I can't talk for every board, but I Chair 3, covering 7 local authorities. This is the only board that doesn't deliver its own training. We do workshops and we do online events and things that we think are really relevant, particularly linked to the National Safeguarding Week. But what we are reliant upon is the agencies undertaking the training delivery themselves, and for us to audit and ensure that the quality of that training and the content of it, the subject matter, is appropriate. I'm really reassured by the new training academy that Stoke and Staffordshire have jointly set up, but there's also a similar process for providers within the care sector as well. And so that's why our budget for training is so small, because under our constitution, before my time, it was decided that we wouldn't do that. We would rely on the others and do the audit and inspection.
Thank you very much for that. I'm conscious I've hogged everything. Are there any other questions? Oh, Councillor McMahon.
I just want to touch on a point that the Chair mentioned at the very beginning of his questions, and that was to do with the hit rate, for want of a better word, of roughly 20%, and how many referrals were coming in. That Adrian, you used the word triaged,
yes,
in order to go elsewhere, and it strikes me that safeguarding is being used as a triage service, and the threshold for referral to safeguarding seems to be quite low in some pretty substantial organisations, and you referred to the West Midlands Ambulance Service as a case in point.
And the police.
And the police. Is there a case for education and training to go there in order to reduce the triage burden, so you can actually get on with the 20% that really you're there to deal with?
Do you want me
to... Well, I'll just make the one point. There is a good argument that you could receive information today that you think isn't relevant, and then you receive information in a month's time that, when you link it to the information you received today, actually gives a picture of risk that actually then does better information to actually decide whether you're going to do a Section 42 inquiry. And that would be the position that the police in particular take. You're dead right. There is always education to understand not only what should come in as a referral, but if it isn't going to be a referral, what might be a more appropriate outcome or route for that information to take. And so it's getting that balance right. So you're right, there is some education, and we've done lots of education. We've done quite a bit with the ambulance service as well, to understand what those thresholds are. But it's also understanding what the structure of safeguarding is. People use that as an overarching reference, but there are lots of different elements, front doors and the like, as to where a safeguarding notification or a request for an assessment or a quality issue or a complaint should be going to. So over to you, Ruth.
Thank you. And I would add to that, because for us, the majority of those that we close are actually from our care providers rather than, say, from police. The ambulance service, so if I look at rate of referral, I can have an argument particularly for the ambulance service. But the majority of those that we close down, as it were, at those very early stages, are our low-level risks regarding our care providers. So we've actually put on, over the last 12 months, 8 sessions, and are putting on a further 8 sessions. We've produced now a lot of leaflets and information that's available on the MyDOS platform to help with that. We're also in the process of testing a provider portal where they'll be able to submit their concerns, as it were, online, and that will help us then to direct that in a more speedily way over to our over to our quality teams. We do, as Adrian says, we have done work both with the ambulance service, and we continue to do work as well with our colleagues in the MASH to ensure that those referrals from police, etc., that come through are more relevant. To be fair to Staffordshire Police, which I wouldn't always like to be at times, that their quality of referrals into us has greatly improved over the last sort of 12, 18 months. So actually those pieces of work do appear to have assisted somewhat. And actually for me, our main focus is around our care providers who submit the majority, and those are the ones that we are in some ways more likely to close at those very early stages.
Thank you. Councillor McMahon, did you want to come back? No. Thank you. Councillor Pardeshi, I think you were next.
Thank you, Chair. I just wanted to take up this issue, Chair, of the data on ethnicity in particular. And we were told, if I heard correctly, that we may not know the true picture because of issues around collection of data, accessibility or whatever. So the chances are, and we can assume, that there are a disproportionate number of members of ethnic minority who are not receiving the service that they're rightly entitled to and need. And for want of a better phrase, there's probably a disproportionate more of them who are suffering in silence. I don't particularly like that phrase or whatever. Chair, in 3 years' time, I will be 70 years old. And for 50 years, I have been hearing, again, for want of a better phrase, one excuse or other, why accessibility is difficult, or we're working on it, or whatever. Years ago, there was that popular phrase, they look after their own. And it was partly used as a reason, basically not to address issues. They take care of their own, whatever. But we're living in a society now where the socio-economic circumstances under which ethnic minority families have to function are the same as everybody else's. They can't make it miraculously work. So this, and when we say there are issues around accessibility and we're working on it, whatever, members of ethnic minorities do not lurk in places where the majority community does not. They access the same schools, the same health centres, the same supermarkets. It's not like we don't have enough microscopes or flashlights to work out where they are. Also, Chair, we're not talking about reinventing the wheel. There are plenty of excellent examples of good work up and down the country. And it has never changed, the fact has never changed that ethnic minority, members of the ethnic minority pay more into the system, tax-wise or whatever, than they receive from it. And I really think we need to make things move a little faster, Chair.
Thank you for that. Ruth, you wanted to comment?
I think I'd like to say I absolutely agree. I can't always understand myself why my messages, why I feel sometimes I'm saying the same thing. So I will offer you this, that when I come here this time next year, that we have made some of those changes and that we are aware of where maybe, and for me the accessibility is our issue, not our communities, it's our problem. So I take that and I hear that and I completely agree with you, and I thank you for such an honest representation as to the position that people are in. So thank you, and I will try not to. Well, no, I won't try. I won't let you down. And that in 12 months that we are sitting here in a different position than where we have been.
Thank you. Did you want
Just
to
to add to that, could I just add
Andrew,
one
yeah, please
very,
do.
very tiny thing, but significant? Under the new strategic 3-year priorities, equality and identifying barriers to all sectors of the community and understanding our communities is one of the individual priorities going forward. So I'm alive to it. There's more significant disproportionality in Stoke, but you're dead right, the 4% is concerning, and we need to do more constantly to make sure that everybody has the information that they need to make decisions and the ability to access services and for us to respond.
Thank you for that. Reverend Metcalfe, I think you indicated.
Thank you, Chair. This is a field which is really quite new to me, so please excuse me if I appear rather naive and not so well informed. And if it's not too presumptuous of me to say so, could I say how impressed I am by the thoroughness and seriousness with which people are addressing this area, the agencies, the county councillors, the partnership board, and so on, and thank them for the work that they are doing on behalf of the vulnerable people in our community. Thank you very much. I just want to pick up, if I may, one little thing that I gained from the earlier thing, and it may not be a very major part of the picture, but it's the situation where a situation is being referred from one agency, one organisation to another, and this is a notorious point at which things can get dropped or lost in the gap between. I'm just wondering how big this situation is where a person or a case has been referred to another agency and it gets dropped for one reason or another. Is it the case that there is no kind of check as to whether the referral has actually been successful or not? And should there not be a culture of ensuring that any referral is actually acknowledged and reported back as having been picked up? It's a bit like the baton in a relay, if you like. If the baton is dropped, then the whole thing falls to the ground. There was another direct dimension of this. Please excuse me if I try and retrieve it from my mind. I'm not writing from notes. Yes, it's the question of a communication actually getting a response, and to say that this has been received, and I acknowledge that we are going to take this up, or the organisation will take up what has been passed on to them. Is there not a culture that encourages that kind of process to be carried out? Thank you, Chair.
Well, you picked up on one of my absolute pet hates, which Ruth knows I talk about this repeatedly. I hate a referral as an outcome. So where an agency gets a referral and transfers it over, they close their case down because they've referred it to somebody else. And yes, everybody aspires to do better, but there are practices, there are work pressures that need to be addressed to make sure that we do retain some kind of duty of care ownership from the originating agency, so that they get that update. And the issue is that we often find, tragically within SARS, where people have died or been seriously injured, that it gets referred to another appropriate agency, and either because the person didn't attend or because they didn't reply to letters or answer telephones, they end up closing the case. And this needs to be referred back to the originating agency, if nothing else, so that the other approaches can be made. And when you have people with care and support needs that need bringing, in Wales for children's, they've stopped the use of the terminology did not attend, and they brought it in. It wasn't brought, and that triggers an issue of neglect. And so we need to really challenge ourselves, and this is the purpose of the board, and we're on it, to make sure that we address this issue, because it features so frequently in SARS, along with other things around the line of sight, where post-COVID people are making telephone inquiries repeatedly, and they don't see the actual state of their home, and then you end up with serious issues that need to be addressed, and often people lose their lives. So there's never one issue either. There's always a co-production of a co-occurrence rather of issues, but this is a significant one for me. So you'll be seeing some input on that in future reports.
Thank you. Councillor Snape, I think you've got the last word.
Thank you, Chairman. Thank you, Adrian. Most of my questions have been asked by the Chairman during his session. At our pre-meet, I was a person who believed you should attend here in person. After having watched it this morning and having been on this committee for 8 years, this is the best presentation I've ever seen. Your knowledge, the knowledge, the way it's been put across every way, giving us all the information, has not been beaten. So I'd like to withdraw my points I made at the preview. It's a good way to act. I'm told you live in Newcastle. You chair 3 other boards, so you're a busy man up and down the country. So can I just say, what an excellent presentation. I go away from here a lot more content than I came into the room. The information you've given us, yourself and Ruth, makes me believe that Staffordshire and our vulnerable people are in a safer place. I'd like to thank you for what you've done. Thank you.
Thank you for your comments.
Thank you very much for that. I think I'll just wrap up by echoing Councillor Snape's comments, and also echoing Reverend Metcalf when he talked about all of those people coming together. I think that does speak volumes. We have been hugely reassured, I think, this morning with the usual detailed responses that Ruth gives us around some of these issues, and also Adrian, again, as I've just said, I echo Councillor Snape's view. It is refreshingly unusual to hear people talk about that they are reassured, that they can give that reassurance and support that things are right. But I think we usually have a good school report, don't we, when it comes to how we look after some of the most vulnerable adults in our society. And again, it's encouraging to see that not only is that continuing, but there are some clear plans to improve that as we move forward. I think coming second to any other local authority about any part of this is an excellent reflection of the service that's delivered under very difficult circumstances, again, to some of the most vulnerable people here in Staffordshire, and we're all fortunate to have dedicated people doing that. So thank you for the report. Thank you for your time in coming and answering the questions. And the recommendations for the members that we receive the report and also that we have an opportunity to provide feedback and challenge, which I hope we all think that we have done. So I'm going to accept those recommendations on your behalf. Thank you again. Thank you for coming.
Thank you. Thank you for having me.
Right. Sorry, an omission of mine from the minutes. I'm too excited to run through. Is everyone happy that I signed them as a true and accurate record from the last meeting? Moving swiftly on then to item 5 and the work programme. Perhaps, Helen, I can ask you just to run us through that.
Yes, thank you, Chair. So there were it's a while actually since we met, isn't it? Because we had the meeting in November cancelled, and it's been replaced by an extra meeting that we've put in on the 21st of March. The movement was because the attainment figures for education weren't available at that time. There is an error in the report because it mentions that the attainment figures, and it says attainment from Capita wasn't available data, and obviously that's attendance data, not attainment. But so that work has just moved to the 21st of March, which is an extra meeting we've put in. There was one other item that should have been at that meeting, and that was an update on the ILAC, so that's the inspection of local authority children's services. We were having an update on that. I did ask for an email update that I could forward to you, which I haven't received yet, but you have got a substantive item on your February agenda. I'll follow up and see if we can get an interim update as well alongside that. There is an extra meeting that's been put in February, so my apologies, you have got two meetings, but the first on the 12th of February is a joint meeting with Health and Care, and it's to look at the new care management system, new IT system. And then your calendared meeting is on the 20th of February. There is at the last meeting there was a discussion around potentially putting together a working group on SEND. We did look at membership of that and started scoping for it, but on discussion with the chair, because we agreed at the last meeting that the chair of the two committees, so health and the chair of this committee, would discuss whether or not the timing was right, and they felt that it would be better to wait until the inspection had happened, because we're expecting that at any point soon, aren't we? And then look at the outcome of that and consider whether a working group is needed to consider some of those recommendations, but that's a decision that will be taken after the inspection.
Perhaps also after elections.
Sorry.
Perhaps also after elections, if it's going to go that far back.
Yeah, I think.
Okay. Okay. And then finally, Reverend Metcalfe mentioned to us at the last meeting about the SACRE annual report, so as soon as that's available, we'll be sharing that with the committee as well.
Thank you very much. There are no other items, so I'll bring the meeting to a close. Thank you all for coming. I understand it's snowing, so we're fortunately finishing early to get back. Thank you again.